Legal.
Very well.
What I'd like to talk about is just how expanding our treatment options for the edentulous patient can occur using a concept, using the all-on-4 concept. What I would like to do is utilize this timeline to kind of get us to a point where we can start to appreciate what we do have with the ability to angle and tilt implants. From 1965, as we first talked about a few minutes ago, through the phase of immediate load, which essentially began to become present in our literature in 1990. The Zygoma implant first introduced in 1997, the guided aspects of implant placement in around 2000, all were remarkable points of history in our evolution of implant dentistry. But this one, the angling of implants, has been a remarkable innovation, at least in my opinion, in implant dentistry. Using angled implants in positions like this has at least been practice changing, certainly for me, and for many of our patients who before were looking at other options, more costly, more invasive, more painful. For them, it has been life-changing. And let me see if I can expand on that. Let me see if I can make that point by showing you, first of all, what we do and can do with tilted implants, and then how we can expand the applications for our edentulous patients, or to be edentulous patients, by using these concepts. Keep in mind, the all-on-4 is a concept. You can't go buy it. It's not for sale. It's simply a different way of looking at implants. It's a different way of positioning implants to enhance the stability and the capability we have for loading them at an earlier time. Keep also in mind, it has nothing to do with the number 4. I will try and wrap a bow around that statement by the end of this presentation. But keep in mind, it is not number specific. It is simply a concept of placing implants in the distal site at an angle, maybe not only in the distal site, so that we can get a success rate, and it's been documented, with angled implants that is at least equivalent to what we experience with vertical implants, and also be able to, with the longer distal implant, facilitate immediate loading, eliminate the need for grafting in a large number of patients, increase the anterior-posterior spread, all the things that Ed has talked about just recently, just a minute ago. And in this, as you see in this 7-year follow-up patient, be able to, in many cases, create an immediate provisional restoration. So these patients can leave in function with teeth with something fixed the day of surgery. Let me show you some of the things that have expanded in my practice as far as applications of patients in placing implants. By utilizing the CAT scan, we can very quickly determine how to treat and treatment plan most of our patients before we ever get to surgery, and that's critical, that's huge. Before, we were very dependent, and this is before is maybe 7 or 8 years ago, very dependent on simple plain films, on a Panorex, to determine if we had enough bone. We couldn't determine the quality of the bone. By the time we got into surgery for some of those patients, we were still guessing as to what we might find. With the CAT scan, we can tell if we have enough bone volume. If we don't, we can plan implant placement. This patient has very thin alveolus in several spots in this maxilla, which might on a previous occasion, at a previous time, have required grafting. This is probably what we would have done, either sinus grafting or onlay grafting for that premaxilla. Today, we can place the implants utilizing the positioning of the implants into the palatal crestal area of the maxilla, getting stability, using an implant that will torque out with the active, for example, at 70 Newton centimeters as opposed to 35 or 40, giving us a better opportunity to take these implants, load them immediately, and in 4.5 to 5 months, provide the patient with a final restoration that looks something like this. For a patient who was looking at grafting and looking at the expense, the additional time, and the discomfort of going through those procedures, this is huge. It makes a big difference in your consult room. It makes a big difference in your exam. When you give a patient an option that doesn't include grafting as opposed to one that does, conversion of sales, it's a huge, huge advantage. Ole Jensen, Mark Adams have created a very nice little article about angling the rest of our implants. Why just the distal implant? Why does it have to be the one in the back of the mouth? Why not the front? And in patients like the one you just saw, with minimal bone or limited bone, angling the anterior implants also creates a greater degree of stability that allows us to immediate load more effectively. We were trying this in Dallas for a while. We were a little bit more free-form than I would have liked, but as you can see, we kind of got it right. M or W, angling the anterior implants as well as the distal implants, has a very advantageous effect on the overall stability of your platform for your fixed prosthesis, especially if you plan to immediately load it. What about the limited amount of premaxillary bone? AIDS touched on this. This is class 1 patient. The patient in whom you see the sinuses in the CAT scan going way up into the premolar region, even into the cuspid site. A patient where you might not have room for 4 implants. It's still an all-on-4, just place zygomas. Distal tilt, mesial tilt. As long as you get the length and the spread, you can go ahead and load these patients immediately, minimize the cantilever length, and anticipate a very good outcome prosthetically for individuals who before would have almost certainly been graft candidates. Before being not that long ago, maybe 7, 8, or 9 years ago, the patient would have had grafts, maybe even onlay grafts. It's nice to know you can do some of this without having to do graft procedures. What about bone density? We never really had a way before the cone beam units came along to determine bone density on patients. And I'm not talking about determining whether this patient is osteoporotic or not. I'm not talking about a medical diagnosis of bone density. I'm talking about a maxillary and mandibular diagnosis of density of bone. And even though the CAT scan that we use, the cone beam that we use, does not officially give you pure readings of density on Hounsfield units, it gives you relative readings. And I would strongly suggest for anybody who presents with bone that looks like on a Panorex, it's kind of thin, maybe a little porous, you go ahead and get the CAT scan. Read the bones, see what the measurements are. And if that patient doesn't have dense enough bone, at least you're forewarned. In my clinic, in our situation, where we have a CAT scan, we have a cone beam, any patient whose readings are under 100 has a red flag on their chart. Doesn't mean we won't be able to load, but it does mean that at the time of surgery, there is a possibility that those implants won't be strong enough for immediate load. The key to doing this whole thing is anticipation, and the CAT scan gives you that capability. 25 Newton centimeters of torque was all we got on an implant that should go in at 70. It's not the good day. It's not the day to immediate load. It's not the day for a miracle. As Dennis Tarnow likes to say, and I think he's absolutely correct, come back and load those later. Put the patient in a denture, which is exactly what we did. We placed white healing caps on. We hollowed out the denture so there's no contact of the base of the tissue, base of the denture against any of the implant sites. Put the patient in a denture for 3 to 4 months. She knew it was coming. It's in the chart. Informed consent. You may not get a fixed prosthesis the day of surgery. Are you okay with that? Your bone is very soft. It's usually chronic smokers. It's usually long-term smokers that are the ones who show up with a soft bone, but you can diagnose it early. And you're not making a medical diagnosis, keep that in mind. But you're making a relative diagnosis that will help you at the time of surgery determine what your plan should be and how the patient should be informed. She went on to a very nice result. 3 to 4 months later, turned that bridge into a provisional, then into a final, and she's been functioning on this for well over 2 years without any complications at all. There is nothing wrong with old school. I'll tell you, in our practice, which is immediate load based, there's 4 to 5% of our patients who look just like this, who only get dentures in the maxilla usually. So far, all of our mandibles have been loadable, but in the maxilla, 4 to 5% leave with dentures. Nothing wrong with that. It's perfectly okay. If you tell me your practice is the opposite, 95% of your patients leave in a denture, I'm okay with that. That's okay too. That's perfectly acceptable. Not everybody has to be loaded immediately. But those who like immediate load and practice it, take advantage of the diagnostic capabilities you have with your CAT scan. It's a huge help. What about skeletal anomalies or skeletal occlusal complications that might present? How about a deep class 2? In a patient whose teeth are unrestorable, severe caries, periodontal disease, we have a matter of simply modifying or managing cantilevers that allow us to treat these patients without surgery. These patients in a previous time might have been orthognathic surgery candidates. Move the jaw to get it in proper alignment. Today we don't have to. We can create a class 1 occlusion by simply changing the angulation of our cantilever, changing the angulation of our abutment, and in this case creating a reverse cantilever, a bigger spread from the implants to the incisor edges than we have from the molar region posteriorly. There's almost no posterior cantilever. It's all in the anterior, but it doesn't matter. It doesn't hurt a thing. Class 1 occlusion in a severe, deep Class 2 occlusion patient, done immediately, transformed and transfigured in one surgical appointment. What about the Class 3 patient? Same thing, just the reverse. The anterior implants are angled and placed in bones in such positions that they can be distally inclined. And the rule we use, the guideline we use, is aim the screw access hole, especially in the lower, at the center of the opposing ridge crest. That usually allows you to create Class 1 occlusion in your final restoration. It did it easily here. Same thing. Severe Class 3, a patient who might have also been a candidate for orthodontic surgery, not any longer. We get a good occlusal rehabilitation, an aesthetic one, a functional one, without having to go through what we used to have to do. Everybody, at least oral surgeons in the audience, will know what VME is, vertical maxillary excess. It's a well-known anomaly. It presents with too much gingival tissue and a lot of bone. Might appear to be an ideal implant patient because of all the bone, because of all the ability and placement capability you have in the amount of bone remaining in that maxilla. Actually, it's a difficult patient to treat because the goal of that patient's treatment is not only to get teeth back that are functional, not decayed and broken down, but also to get rid of the gummy smile. So you want to very carefully plan this patient. You've got plenty of length. You've got big apical triangles of bone, the one circled that you see on the screen. Excellent example of the bone you can't have to use in patients like this. And even with good density, you've still got to be careful to plan enough platforming, enough bone reduction to be able to place implants in proper position and then take the transition line of that prosthesis up and under the lip. So we make careful measurements of where the resting lip line is, where the smile line is. We make careful measurements in the mouth as we reduce bone. We use a clear implant bone reduction guide, open up the palatal surface, and it helps us place our angled abutments in proper position for the transition, which eventually will lead to a fixed prosthesis that looks like this and a before and after that looks like this. Again, a patient who would possibly looking at Lefort osteotomy to raise the maxilla and get that bone up and out of the way so we can eventually build an implant bridge. Not necessary, as long as you plan carefully. A lot less intrusive treatment planning for our patients based on this concept of the all-on-4. I show this patient because I was honored to treat her. She's a dentist. It's the second dentist I've had in my practice with ectodermal dysplasia. The point here, of course, is one, not all the teeth made it. There's a lot of agenesis going on here. And two, that you can still make a transformation here that's quite dramatic. In an individual who's really not sick, who really hasn't done anything wrong as far as taking care of their teeth, it's just a patient who just got dealt a bad card for dentition. And in this case, what we were able to do, even in the thin zones that you see here with the iCat in sections, be able to plan the placement of the implants, angled and spaced, so that they all engage good bone, so that they all allow the definitive prosthesis that you see in the mouth, both here and on the radiograph, to be placed as an ideal, and initially as a fixed prosthesis, and finally as an ideal occlusal scheme for this young lady. We talked about age. The age of these patients today is a lot more relative than it used to be. Every speaker so far has mentioned age as a complication, age perhaps as a contraindication to implants. Let me see if I can change that thinking just a little bit. This young lady, beautiful lady, by the way, smart, bright, as you can see, very well dressed, presented to the clinic with one complaint. She really wanted to be able to smile at her grandchildren. Now, as you can see, she's a senior citizen. She was in generally good health, a few cardiac issues, but she's going to require some medical clearance, but nothing to really worry about. She's healthy. She has, as you can see, a smile that reveals a lot of broken down teeth. For her grandchildren, children especially, who simply see things differently than we do, it did scare them, and she was a little bit embarrassed and even conscientious about going to family functions with a smile like this. You can see that there's lots of bone in this mouth. We went through a different set of diagnostic procedures to get to a final plan for this patient. In patients who have age and aged nicely as she has, even though There is very little wrong systemically. You do usually end up with inverse smile line. You start to show more lower teeth than you do upper. That's something you'd like to reverse. It's something you can plan on reversing as you go through the treatment planning scenarios with patients like this, mounted casts. Look at the amount of bone in that maxilla. Look at those tuberosities. What if you decide to do a denture in this patient? That might be life-threatening, taking those tuberosities and those tori off alone. So we looked at dentures. We looked at partial dentures. We looked at all different options for her, even implants and immediate load. And what we finally decided on was maxillary and mandibular full arch implants placed with loading the same day. I forgot to tell you, she's 102 years old. She is in remarkable health. She's not the normal 102-year-old, but she's a whole lot more like the normal 85-year-old that you'll see today. Age is not what it used to be. Our patients today are living longer, they're in better health, their teeth may break down, but they're telling us that they're only as old as they feel, not as old as they really are. By the way, when you're dealing with patients like this, especially in the upper ends of the century, you usually end up dealing with the families as much as you do the patients. So keep that in mind. We went through the family. We were very careful. We did actually. She was born in 1906. We went very careful to get medical power of attorney through her son and her sons and get permission from the family to do all the procedures we did. We were in a general anesthesia in a hospital setting just to be safe. I thought we could get both jaws done. The anesthesiologist said, yeah, we've had a good day. Been here a couple of hours. Let's not take a chance. Finished the upper first. Came back a couple of months later, did the lower. This is the upper after 1 week. And look at her again. She's beautiful. She's made up. She's beautiful, well-dressed, beautiful hair. Very well taken care of. Takes very good care of herself. Eventually able to get implants in the maxilla and the mandible. And last November, we were able to celebrate her 105th birthday. She got another 3 years. And I think she'll get more out of the teeth we gave her. She's a whole lot happier with herself, a whole lot more presentable in her own mind to her family. Those kinds of things are huge. They're huge in our elderly population. So this individual who I would have had a tendency to write off in an earlier time is now a patient that I look at more carefully, a patient that I feel I can treat with implants, using immediate load, using the all-on-4 concept very effectively today. What do the statistics tell us about this 4-implant maxilla or mandible? This is a slide I took from a presentation that Paula Malo did in San Diego at the AO meeting in 2009. And you'll notice that the maxilla and the mandible have high degrees of success, but you'll also notice that the numbers of failed implants in the maxilla versus the mandible are something like 5 to 6 times more failures in the maxilla than the mandible. We put together some statistics in Dallas, which I'll show you in a moment, but if you're looking for articles that validate the all-on-4, especially in the maxilla, you'll find yourself lacking in citations in almost every journal. In fact, that's been made an issue of. The systemic review of immediate load, done in 2006 by DeFabro, also noted that there's a paucity, there's a lack of documentation to support immediate load of 4 implants in the maxilla. So keep that in mind. Keep that in mind. It was impressing to me to know that we're doing it every day, but I really don't have a lot of literature to back me up. So we did a little study. We looked at our Dallas results from April of 2008 through December of 2010, where I never thought we'd do this many implants, but we did over 550 jaws. We're coming up on 1,000 jaws next month. We did over 2,000 implants. We had about 5 to 6 times more implants fail in the maxilla than the mandible, yet we had reasonable success. Reasonable success. The problem is, a failure in the maxilla is a whole lot more difficult to deal with than a failure in the mandible. I don't have time for the patients that demonstrate that point, but dealing with failures in the upper jaw, even one implant failing in the upper jaw, can be very, very difficult. So what I did to try and find out what might allow us to either diagnose early patients who might be candidates for failure, or to at least minimize the number of failures that we were seeing in the maxilla, was to go back and look at the charts for every patient during that period who had a failed maxillary implant. I'm just going to talk about the maxilla for the rest of the time here. But for every patient, a retrospective review of the chart. And I don't have time to go through all those charts. None of us do. But I can go through 41 charts and look for what might have been commonalities in presenting characteristics among those patients that would allow me to maybe profile something to look for at the time of treatment planning for those patients. I looked at this list right here. This is just an arbitrary list, just things I thought about looking for that might enhance implant failure, might contribute to implant failure. And what I came up with was this. Opposing natural dentition seems to be more harmful than an opposing natural implant bridge. Poor bone density. 15 out of 19 patients had poor bone density who presented with an implant failure. Male patients far more likely to have a failure than a female patient. And almost all of our failures were in the posterior implant zone. That posterior implant takes 10 times more load than the anterior implant. That's why it needs to be solid. Smoking and bruxing, they're in there somewhere. But I couldn't really put them in the high priority category. So I listed some things, primary factors, secondary factors, and I went to our patient population and began to start looking at them differently as we started to diagnose and treatment plan before surgery. I wrote an article with Billy Phillips, our surgeon at the time, published last December in the JPD, which actually is exactly what you're seeing now. The same statistics are in there. And what we've done since then, and remember I said, I want to put a bow around the number 4. This is it. All on 4 is not about 4 implants. 4 may not be enough for some patients. And these are those some patients, the ones with soft bone. We find out about it early. We can diagnose it very simply using the CAT scan, measuring Hounsfield units in areas of bone that we're going to place implants. If it comes up in our situation at 100 or less, it's a red flag patient, they get more implants. That, I think, makes a difference. I can't say for sure, but I think it does. And I'll show you my statistics for this patient group that at least so far support that statement. More implants in a compromised situation is probably a good idea. What about surprise bone? What about a patient whose panarex looks like, you can't see it very well here, but it looks like there's good bone there. It looks like there's enough bone vertically in that maxilla to place implants. Yet when you do your panoramic and compare it to your ICAT, your cone beam, look how thin this premaxilla is. Look at that bone, how wispy it is, how atrophic that area is. You can't even see maxilla in the solid bone model. When you see that golden bone model that looks like you can see through the maxilla, even if it looks like you've got vertical bone, you've got a very difficult treatment in front of you. Could be a graft patient, could be a patient who needs more implants. Fortunately, we found that in the tuberosity region, probably as a result of this being a combination syndrome at one time, there was bone. There was more bone than we actually thought. So we were able to put implants in the posterior region, count them, there's 10. We shotgunned. This is as many implants as you can get in a day. We didn't close the implant locker. We went right for every implant we could find. Put in 10, ended up with 9. I'm happy with that. Ended up using 7 of those 9. As you can see, we didn't need the 2 distal ones because we had the cantilever covered. In fact, if you look at that clinical slide from the occlusal view, the cantilever is actually in front of. The final implant doesn't have a cantilever behind it, so we've got plenty of cantilever support, plenty of implant support, plenty of space for resin and to build a strong enough bridge. This is exactly what we did. But a patient who was treated with a denture, I don't know if you noticed that or not, but treated with a denture as an interim, not a fixed prosthesis, but also treated without a bone graft and without zygomas by simply utilizing bone wherever we could find it and using angles which allowed implant placement maximally in that bone position. Opposing dentition, every one of these today in my practice gets 5 or more implants. If you have opposing natural dentition, every one of these gets 5 or more implants. It's just routine now. It's standard in the practice I have. How about the trifecta? How about the implant trifecta? A bruxer, a horizontal bruxer. That's critical. Not vertical, but a horizontal bruxer. Opposing natural dentition, male patient. These patients can do tremendous damage. Horizontal bruxers can knock apart anything I can build, whether it's made of porcelain, whether it's made of plastic, whether it's made of tinfoil. They can knock apart anything I build. So these patients, to me, when I see that kind of bruxing pattern, especially in a single arch, is a patient in whom I'm going to place as many implants as I can. I wanted more. I wanted more than 6 in this patient. We had him in provisionals. He started knocking the provisionals apart. He started grinding the teeth. First time he broke a tooth, I said, that's it. You're going into balance. So I got my burr out and put him into balance. So every time he grinds, he's in perfect balance to start with, not end with. He's starting with perfect balance, and he'll just grind those teeth some more. Final restoration, he's going to do the same thing to these teeth. He's going to put wear patterns in them after about a year that may have us replacing teeth at 3 and 4 year intervals. But at least we've got implants. We've got enough implants to counteract the stress he can generate because of his bruxing patterns, because of the opposing natural dentition being so uneven. That's the trifecta. That's the patient I would advise you can be the most difficult of all the ones I've shown you so far to diagnose and to treat, especially in single jaw situations where you have an opposing natural dentition or even fixed prosthesis in a horizontal bruxer. Use more implants, or at least place more implants, even if you don't use them all. That's the bottom line. That's the goal for us today. So to summarize, in that profiling group of patients in that time period from 2009 to 2010, the distribution of implants during that time period was about 25% with 5 or more. The rest were all the standard all on 4. Since that time, and I'm putting the data together now, but since that time, that 24% number is up to about 44%. More implants. We're using more implants as we see more indication for them. 5 to 6 implants is the spread that was most often used. 7 or more implants, as you've seen in a couple of patients, not very many. And overall results, implants and failures. 2 failures, short period of time. It's a meaningless statistic. This is not data. This is not science just yet. There's more time that needs to be studied. This concept needs to be looked at over more patients and more time. But so far it's encouraging that at least more implants in the challenging patient, in the compromised patient, are probably required, are probably indicated. Thank you very much.